Hello. Thank you for being here, and this is the opening of Vascular Art Theater. Good morning, everyone, and welcome to the Act 1. This is the day I had to invent my own tool, and this session is not about the guidelines or the IFUs or any brochures that tells you anything. Today is a moment inside the angio suite when reality doesn't match the textbook. So all of us has faced this before, that moment that you have a tough case in angio room and the lesion is laughing at you actually. Anything is not working and all turns against you, then you have to think more, think deeply and find your own tools. Now let me introduce my colleague and my friend, Dr. Bruno Miligara. This session is about those cases and the creativity. And honestly, this is no better person to walk us through this creative battlefield than Bruno. Bruno needs no introduction in this field of creativity, and he's known only for not only for skills but also for his imagination. So when those devices this doesn't exist and you have to build your own way through those cases when the technique is not described, and you have to invent something to finish the case with the best result you can, and when things go sideways sometimes and somehow it makes them go forward again. So, ladies and gentlemen, Dr. Bruno Miligara from Italy.
Thank you, Ahmed. Good morning to everyone. It's a great pleasure to have this opportunity this morning to present, to discuss with you about something different, what happened in the real life in our operatory room sometimes when we don't have the right material to treat this patient. Okay, this is the patient, a typical CLTI patient with an ischemia, with renal chronic disease and also heart disease. But this patient presented in our department with this infection. So this is really a foot attack, so an emergency situation. So the first question, of course, when we find a patient like this is to decide which is the first treatment choice. So of course, is a CLTI patient. The first choice is to treat the ischemia, or the first choice is to do directly the foot surgery or to use the antibiotic therapy to treat the infection. Of course, in my practice, the first thing in case of a foot attack like this is to do a foot surgery, or better, to treat this patient aggressively with a foot surgery, removing all the infected or the ischemic area, and then now we have a patient that is a CLTI patient. It's a patient with an advanced ischemia, treated many times before with open surgery, so 2 above the knee and 1 below the knee bypass, all occluded. So now this is the stressful situation for us because, of course, is a complex patient with infection with CLTI. And this is the angio of our patient. This angio is showing a complete occlusion of the proximal profunda, a complete occlusion of the SFA, a complete occlusion of the previous bypasses, and also an occlusion of the POP, and an anomalous tibioperoneal trunk, again occluded, and so this is the reason of this really poor flow into the foot. Of course, the angio is a CO2 angiography because this patient has a stage 4 renal disease. So now the second question. This is the angio. We have to decide how to treat this patient. The first possibility, of course, is to do a redo bypass, but this patient had 3 previous occluded bypasses, and we know that in case of a non-available autologous vein, the redo bypass is not acceptable, not a really good long-term result. Is a really tricky situation. We can do a thrombectomy of the previous bypass. Sometimes the result of thrombectomy are better than the redo surgery, but again, in this case, we have 3 previous occluded bypass. So we can choose the last opportunity, last chance, that is to percutaneously reopen the occluded native arteries. And this is what I decided to do in this patient. So, of course, the first thing is to treat the easiest situation, but also a really important artery, that is the occlusion of the profunda. I reopened the profunda in order to try to obtain indirect flow, but to improve the flow into the genicular area. And then after that, of course, we have to try to obtain a direct flow. And so I did an aggressive subintimal revascularization of the native SFA. But unfortunately, when the wire arrived at the hunter level, the wire stopped. I was not able to cross this part, and so probably this due to the previous bypass surgery, so the interruption of the SFA in this point. And this is a really interesting point, in my opinion, because always we stress the need to respect artery in endo to avoid a problem with the secondary bypass, but sometimes we have also to respect artery when we do the open surgery. So now this is a stressful situation because I tried to cross this lesion, but was not possible. So what can we do in a situation like this? I decided to realize a totally percutaneous endovenous bypass. We published this technique in 2021 on the AGVS. So using the Pioneer Plus catheter that is a reentry system, IVUS guided reentry system, I puncture from the SFA to the femoral vein, and so I place a 1/4 guide wire from the artery to the vein. After that, of course, I try to puncture from the vein to the artery, but the vein is too big, and so was impossible to cross from the vein to the artery. So I decided to do a retrograde puncture of the proximal patent ATA, and arriving with the guide wire till the POP area. At this time, in retrograde, I use the Pioneer Plus in the same way, so from the POP artery to the popliteal vein, and at the end, I have 2 wires into the popliteal femoral veins. So I snared the distal wire to the proximal sheath, and so now the wire is going from the SFA to the femoralis vein, again into the popliteal artery. To complete the procedure, of course, I have to place a cover stent. This is a Viaband 5 mm, 150, going from the SFA to the femoralis vein into the POP artery. Of course, I complete the procedure fixing the dissection, the extensive dissection of the SFA, placing 2 super stents, the first one with the Presto technique to arrive just at the origin of the SFA, the second one connecting the proximal superior with the Viaband. And so, of course, I complete the procedure treating the below the knee arteries. And this is the final result. So in the final angio, we can see the patency of the profundo, the patency of the SFA. In the red ring, we can see well the endo bypass going to the femoralis vein, and this improvement of the flow into the foot. This allows us to obtain the healing. Of course, the healing is not easy in this case, so we did negative pressure, dermal substitute, and autologous skin. But I think this is the most interesting result. After 6 months, the Doppler scan showed the patency of our endo bypass and no DVT into the femoralis and popliteal vein. So, just to conclude this presentation, this case, I think the bypass failure is a really tricky situation. We can solve this in many different ways, but in case of a really, really complex case with the impossibility to cross the native artery, the use of this Piper endo bypass could be a solution. Thank you.
And wow, just wow. This is what actually we created the Vascular Art Theater for, those marvelous cases in the angio suite when you cannot find a solution, then you work everything together to find a way through. So let's start with my question. I have 3 questions for you. The first one, this was the very last resort for this case. So is there any moment you think to abort during the procedure?
Yes, from the beginning. No. When I was in the SFA and I thought that the SFA was ligated in the previous open surgery, I spent 10 minutes just to try to understand what we can do, but at the end, okay, I love this device. Unfortunately, now the Pioneer Pass is not on market in Europe, but I love this device. I use this also to do the DVA, and so I thought immediately to this device to have the possibility to connect the artery with the vein.
Okay, fair enough. So my next question, if we had the same situation in angio suite tomorrow, would you think differently or do the same?
No, probably I will do the same. I did this endo bypass till now in 5 cases in my life. But yes, I think I don't like the idea of the endo bypass that is on market because it's a long bypass through the vein. Why to put a long stent in the vein? But in a case like this, is a 10 centimeter of 15 centimeter of via band. So I think in this case is an extreme case. Of course, it's not my first choice to do an endo bypass. But the first thing I thought about the risk of the DVT. Of course, but the vein is really big and with a low dose of anticoagulant therapy probably is possible to avoid. Also in the study about the endo bypass, the DVT is 3%.
Okay, so in your opinion, what is the greatest lesson we have learned from this case? Well, in a very short statement.
The most important is that I said before, when we do open surgery, probably we have to think about the possibility that open surgery doesn't work, and so we have to respect the artery for an eventually secondary endovascular treatment. Thank you.
So finally, we have the conclusion that we are all facing the same situations in Angio Suite. We are all facing those hard times when you cannot find a suitable tool to do what is you're thinking about, and you have to think out of the box to find a way to finish the case with the best result to get a benefit for your patients. So those are the main core of our work in Angio Lab. Not only the guidelines, not only the IFUs. Sometimes you have to pave your way through. Thank you, Bruno. Thank you so much for this act. It was very, very, very interesting. Thank you. I'm calling for the next act in Vascular Art Theater, Dr. Amos Shafai and Dr. Muad Salam.